I think efficacy can only be improved if we identify the cause of the difference, right? So in terms of FIM efficiency, which I've reported in my study, which includes the FIM score change over the number of days at rehab, the only way to effectively improve efficiency, which would in turn be considered rehab efficacy, would be to either increase the numerator, which is the score difference, or decrease their rehab stay, which is the denominator. That would mean ensuring that this particular population gets the care they deserve when they are in rehab. If that means a few more hours per day in rehab during their inpatient stay, I think we should have the bandwidth to accommodate that. And the good thing is all these aspects are known before. So it would be reasonable to anticipate their outcomes earlier upon discharge from the hospital and plan accordingly beforehand. Another option, which is not necessarily favorably considered in this socio-demographic group, would be to follow up that rehab stay with a short stay in a skilled nursing facility that will provide them with the rehab care and ensure patient safety too before discharging the patient to home. Another thing to note is the aspect I highlighted before in terms of women having a higher burden of premorbid disabilities and a longer lifespan. I think we as neurologists and even primary care physicians need to be more active and work on primary prevention of strokes in this population. We have to be more aggressive in treating their AFib, their hypertension, their diabetes, their cholesterol levels, all the factors that are potential risk factors for stroke, both ischemic and hemorrhagic. There's plenty of research on the pharmacogenomics and reported racial differences of genetic polymorphisms. And lastly, if we know that African Americans hold stronger beliefs about particular aspects of their care, then it is our responsibility as healthcare providers to not only acknowledge, but also try to accommodate this cultural awareness in our clinic and in our counseling when we see patients and their families. Because once they are discharged, we are not the ones who will be with them at home. It will be the families, the caregivers who will need to support that patient. And we must do our absolute best in improving access and quality of care for minorities.